Good morning. Today we will see the second stage of labor. So, in this we will see the preparation, observation and conduct of labor because it is a big topic. I'll be including in two or three videos. So, we will see the beginning of the second stage of labor. So first we will see the physiological process which happens during the second stage of labor. We have in the first stage of labor we have seen so many, there is uterine factors, mechanical factors we have seen in the first stage of labor. So we will see what about the second stage of labor. The first physiological process which happens in the second stage of labor is descent. Descent begins during the first stage of labor. It is not solely as a second stage, but it's as we have seen, the descent will start in the first stage of labor. Then the rate of descent is nearly 1.6 cm per hour in a nulliparous woman and nearly 5.4 cm per hour in a multiparous woman. Second physiological process is uterine action. The contraction which the patient is having on the first stage of labor, that will be increasing the strength and the duration will be increasing. So it will be lasting nearly 60 to 90 seconds and it comes often within 2 or 3 minutes interval. And rupture of membrane. Membranes rupture spontaneously at the beginning of stage. It is better to preserve the membranes as far as possible, because when the rupture of membrane happens early in the first stage or before the first stage, there's a chance of infection is more. So we can preserve the membranes as far as possible. Then third is soft tissue displacement. The two soft tissues which involved in the second stage is the rectum and the bladder. The uterus anteriorly it is in the bladder and posteriorly the rectum. So the anterior soft tissue, that is the bladder, pushed upwards and posteriorly the rectum flattened into the sacral curve. The levator muscle dilate and thin out, become depressed laterally. The perineal body flattened, stretched and thin. Fetal head is visible at vulva, advancing with each contraction. So these are the four physiological processes which happens in the second stage of labor. So the first one is expulsive contractions, the strong desire to push. The rupture of membrane allows the amniotic fluid to drain out. The smooth, hard, round fetal head mounts the equal pressure on the soft vaginal tissue, and the fetal axis pressure increases the flexion of the head, resulting smaller presenting diameter, more rapid progress and less trauma to both mother and the fetus. And the forceful expulsive contractions cause muscles of the pelvic floor get stimulated, and this phenomenon is termed as Ferguson reflex. At this stage, the contractions will become stronger and become expulsive and beyond the control of the woman. Second is the rupture of membrane. The dilatation of cervix, gaping of the anus. Gaping of the anus means it occurs at the fetal head reaches the pelvic floor. It begins during the last of the first stage of labor. When this occurs, the fecal matter expelled out. The cervix is fully dilated and the woman may ask for a bedpan as think that it is a bowel movement. Progressive visibility of fetal head at the introitus and congestion of vulva. The maternal physiological changes which happens in the second stage of labor are include. First one is blood pressure. It may rise 15 to 20 millimeter of mercury with contractions. Because of the contractions increase vasoconstrictions and patients anxious, pain. All these will contribute to increase in the blood pressure. Second, the basal metabolic rate will be increased. And third, the pulse rate will be slightly increased. Temperature also will slightly increase because of the increased BMR. GI changes, there is reduction in gastric mobility and absorption of the content. That is why we reduce the intake of food in the first stage of labor, because gastric motility will be decreased and there will be decreased absorption of the food. So if the patient had any food, it may cause into the vomiting or the regurgitation. And the phases of second stage. The second stage is divided into two phases. First one is the latent phase and second one is the active phase. The latent phase includes the descent of fetal head and internal rotation takes place. That means till the crowning comes in the latent phase. As the head descends in the birth canal, the strong expulsive urge to exert a pressure occurs and women should be discouraged to do as it may cause exertion because the patient will have a strong desire to expel the content outside, but this may cause the exhaustion. Second is active phase. Active pushing on the second stage of labor start after the crowning of the head occurs, that otherwise the hairline can be visible at the vulval outlet. During the active phase, the woman encouraged to push, follow her own inclination. Maximum effort in pushing at the height of the contraction will benefit the woman as it allows the vaginal muscles to become taut and prevent bladder support and transverse cervical ligaments from being pushed down in front of the baby's head. And this also helps to prevent prolapse and urinary incontinence later in life. Many mothers may vocalize loudly that this may help them to cope with contraction. The atmosphere of the labor room should be calm, quiet, peaceful, supportive, as well as unhurried. So if it is not unhurried, or there is any other tensions occur, it may again increase the tension of the patient. Positions during delivery. Most preferred position is semi-recumbent position or flat lying. The thighs abducted is using during the labor. In this, mother's weight is on her sacrum, which is directs the coccyx forwards and reduces the pelvic outlet. It provides clear view of the perineum to the midwife. In addition, it supports a newborn and a mother through the birthing process. Other positions used in delivery include left lateral, supported sitting, squatting, kneeling, standing, knee chest. The selection of the position depends upon midwife's skill in conducting the delivery in that particular position. Sometimes the woman may need to have the delivery on the sitting position or a squatting position, but we cannot accept that when if the person who is going to conduct the delivery is not familiar or not skilled enough to conduct the delivery in that particular position, because it may harm the mother or the child or both. So any position which select during delivery depend upon not only the woman but also the person who is conducting delivery and the skill in the conducting delivery in that particular position. So first is the preparation of the patient. Maternal position with exertion of avoiding supine position, mother may assume comfortable position, and semi-recumbent position is the most preferable positions. And perineal cleansing. When delivery is imminent or the hairline can be visible at the vulval outlet, the skin in the lower abdomen, vulva, anus and upper thigh is cleansed with a proper antiseptic solution. And perineal cleaning needs 6 swabs and clean sequentially as shown in the numbers. So the first one start from like this, and second on the left, and clean according to the direction is the arrows shown in this picture. Second is observation. First was the preparation of the mother. Second is observation. The things to be observed are the first maternal condition, fetal conditions, uterine contraction, and progress of labor. Maternal condition include emotional condition of the mother, the pulse quarter-hourly, and blood pressure hourly we have to check. Fetal conditions, it can be the fetal heart rate can be checked either by continuous or after each contractions. Liquor, when the membranes are ruptured, we have to check for the liquor for any meconium stain. And uterine contraction has to observe for its strength, duration, frequency, assess continuously. And the progress of the descent, it has to be observed in every 30 minutes. And mechanism of labor. We will see the mechanism of labor. So the principles, whichever may be the mechanism, if it is LOA, ROA, LOP, ROP, SO, LSA, whatever may be the mechanism, there are 3 principles which are common to all mechanism. They are descent takes place throughout the labor, and the descent not starts in a primary mother. The descent starts nearly 2 weeks before the onset of labor, but in a multiparous woman, the descent starts after the onset of labor. You may wonder why it is, because in a primiparous mother, the abdominal muscles are so tight, so it may start before the onset of the labor, 2 weeks before that is why we call as the lightening. So that means a primary mother who had the descent has taken place or lightening has taken place, that is a positive indication for vaginal delivery. And the primary mother the descent is not engaged yet even after the 40th week. Even at the 40th week, we have to check for any cephalopelvic disproportion. And second principle is whichever part bleeds and first meet the pelvic resistance will rotate anteriorly until it comes under the symphysis pubis, and whichever emerges from the pelvis will pivot around the pubic ball. These are the three principles. Whichever the mechanism, these three principles has to be followed in the mechanism of the labor. So in lie is longitudinal and position is in LOA. Lie is longitudinal, presentation is cephalic, position is LOA, attitude is flexion, denominator is occiput, and presenting part is posterior part of anterior parietal bone. And the main movements are DFICERILEL, that is descent, flexion, internal rotation of the head, crowning, extension, restitution, internal rotation of shoulder, along with the external rotation of the fetal head and lateral flexion of the body. So the main movement are descent, flexion, internal rotation of the head, extension, restitution, and internal and external internal rotation of the shoulder, along with the external rotation of the fetal head and lateral flexion of the body. So the main movement, first is descent. I have explained this early. So second is flexion with increasing during labor as a result. For a demonstration of this mechanism, you can watch my videos which is on LOA, mechanism of labor, LOA. I have demonstrated how this happens. So you can watch. If you have any doubt, you can ask me. And the flexion, it increases during the labor to result in the smallest presenting diameter, which will negotiate the pelvic easily. At the onset of labor, the suboccipital front that was 10 cm, but increasing flexion, the suboccipital pragmatic 9.5 will be the presenting diameter. And third is internal rotation of the head. Occiput is the leading part, so it comes according to the second principles. It comes and meet the pelvic floor first and rotate anteriorly. During contractions, the pelvic leading part will be driven down, and the resistance of muscular tissue brings the rotation. So resistance is important factor in internal rotation. That is why there is delayed rotation in epidural anesthesia. The muscles are gutter shaped and slope down anteriorly, so whichever parts meet the pelvic floor will rotate 1/8 of the circle. Along with the internal rotation, the crowning happens. Crowning means the hairline is visible at the vulval outlet and the head will no longer recede back after the contraction. Next, extension of the head. The head will be delivered by the movement of extension. The sinciput, face and chin will sweep the perineum. And the third principle, whichever comes out of the pelvis, will pivot around the pubic ball. So in this case, there will be a small twist in the neck which happen in internal rotation of the shoulder. Internal rotation of head of the baby is corrected by a small untwisting movement that is known as the restitution. Then internal rotation of the shoulder along with the external rotation of the head happens and lateral flexion of the body. So before the engagement, the fetal head will be like this, and after the engagement and descent, complete rotation, so it rotates anteriorly, and so the occiput comes under the symphysis pubis. And there is extension of the head, and the head will be turned towards the mother's right thigh, and the delivery of the anterior shoulder. The shoulder has to be delivered one by one. So first we will deliver the anterior shoulder and slowly lift the baby up so that we can deliver the posterior shoulder. So this is how we have to deliver the anterior shoulder. We should not give traction. We should not apply traction on the fetal head. We have to hold the baby, and then we have to slightly move the baby upward and downwards so that anterior and posterior shoulder can be delivered. So in second stage of labor, as soon as the baby is delivered, we have to clear the airway, assess the respiration, resuscitate if necessary. Clamp the cord when the pulsation ceases and leave 3 to 6 inches of the cord on the baby. Obtain blood for fetal labs as per the institutional policies. Some hospital the cord blood will be taken for a cord TSH and HB and doping, all those things. So according to the hospital policy, we can take the blood. Then clamp means we have to apply the umbilical cord clamp and leave nearly 5 to 6 in a view that if the patient need any external transfusion for that. Observations during second stage include uterine contractions, its strength, length and frequency, descent of the presenting part. Fetal conditions include the FHS and lichorrhamny. Maternal conditions include the maternal heart rate, means pulse rate, BP and the temperature. And pushing the urge to push even before the vertex visible. So we should not allow the patient to push before the vertex available, because if the mother start to push early, it may cause vaginal edema, and it may seize all the energy the mother will have. So once the fetal head is visible, mother will not have no longer will have any energy to push it. So we should not allow the mother to push before the fetal head is visible. Thank you. The continuation will be there in the next video. You please do watch that also. Okay, thank you.